So I trust everybody could see the majority of my slides. Making sure that my bar down below my computer is going to go away. So, all right. So the title of this presentation, besides the whole ethical medical challenges and surgical challenges, I really wanted to call more attention to the questions that we ask. My patient has endocarditis due to IV drug use. Now what? And it's that now what that interesting to note has variations across medical, surgical specialties, and even mental health communities, or the lack thereof mental health communities involved. So I have no financial or other interest to disclose. The clinical and research work presented was not industry sponsored. I got a little bit of grant funding from a clinical ethics project for part of this project for about $2,000, and that was about it. Um, so I'm going to go over a couple of clinical ethics case presentations that were the impetus for this study. I'm going to provide you with some mixed method study outcomes of one component of this study, and then some recommendations for mental health, medicine, and surgery professionals and community members. I'm glad to see that we have a lot of folks working with our community and advocates for our patients. So just a little bit of background. The age-adjusted rate of drug overdose deaths, as you can see, continues to increase. This is not new information for us. Rates are decreasing for people ages 15 to 34, and we're seeing more individuals with IV drug use and then complications for those 35 and older. Between 2021 and 2022, rates increased for all race and Hispanic origin groups, and except those of Native Hawaiian or other Pacific Islanders. And also during this time where the initial data was collected, the rate for synthetic opioids rather than methadone increased 4.1%. And as you guys know, being in many of you in Ohio, this is not new information to you, but it is related to some of the ongoing health issues that are complicating the IV drug use in particular. So here's just a brief overview. This is actually collected from the National Center for Health Statistics and National Vital Systems, Statistics Systems. Just the increase of age-adjusted rate of drug overdose deaths by sex. So just to give you a picture of the increase that we are seeing. So one of the complex health issues that does arrive with IV drug use and also combined IV drug use and opioid use that we're seeing in patients in our area has been ongoing increase of endocarditis. And endocarditis is, the mortality rates are increasing. It is a complex health issue where if it's bad enough, patients will need valve replacements, heart valve replacements. And for those who are continuing to use drugs without the necessary support are often denied surgical treatment. Medical treatment is often the first line, using big, quote unquote, big gun antibiotics. But as we're seeing more and more severe cases, those antibiotics are not working. And so we are seeing more severe cases. And oftentimes it's because individuals are not coming to healthcare providers quick enough. And the types of drugs that they are unfortunately addicted to are just causing an enormous amount of problems of endocarditis. And patients tended to be younger, Caucasian, early on in the early 2000s, even kind of mid 2000s, but now we're seeing 35, 45-year-olds as a portion of our population. And with aging populations and older populations, the surgical outcomes, even the medical outcomes, can be quite trying, especially if individuals do not have support systems, which I'm going to get into. We conducted, I worked with a cardiac surgeon, Dr. Furstenberg, and after seeing a lot of clinical ethics cases that I had with surgeons in our local area turning patients down, not necessarily because of justifiable medical and surgical reasons, but oftentimes because of biases and the fact that patients did not have support systems. Oftentimes patients were turned down after utilizing antibiotics, not having access to heart valve transplants. And so my colleague and I, and he working in the clinical arena, recognizing some of the biases among his colleagues, we started to dig a little bit more. We really wanted to see, our surgeons, our healthcare professionals turning individuals away from access to medical and surgical care simply because they are IV drug users, or are there other factors going on? So we did we looked at a retrospective initially of 180 patients, 54 IV drug use from 2011 to 2006. This was kind of our foundation research that we started building our own research projects. And we're looking at, the median of months of drug use, the type of care that was given. Majority of those patients were given the quote unquote big gun antibiotics. But then we were also recognizing that many of those patients were not getting surgeries that would actually qualify for their surgeries. Then we dug into the literature a little bit more, and multiple studies have found that 60 to 81% of IV drug use patients do return to their drug use following surgery. So one of our hypotheses was, well, is that one of the reasons or impetus that some of our patients in our own area were being turned away from the possibility of surgery? And so we looked at those factors, as well as what are the support systems that are out there? What are the mental health addiction support that patients are receiving or not in a variety of clinical institutions? The other initial study that we conducted, we looked at decisions of operations. And so the decision to operate on IV drug use patients a second time, it's not even the first time, but a second time, after relapse, basically of reinfection, is highly contested and physician dependent. What we were finding in our own work originally is that while many surgeons have been working with the medical teams after the antibiotics are used, they will try a valve replacement. But oftentimes those valve replacements are done because of either a hospital policy, and we're going to talk about hospital policies and lack thereof. Most of our institutions don't have very clear policies regarding this, or because of the pressures to treat, especially individuals that could have a successful surgery itself and a surgical outcome, even though long-term outcome of basically getting back into the relapse was very low, or actually it was high. And so when we did mixed methods research, we did survey, and we did interviews. A lot of the surgeons that we had contacted basically indicated that they were pressured to even do the first heart valve replacement, and they certainly did not want to do a second one. So we wanted to look at some of these reasons on a national level. And so we looked at designing an anonymous survey instrument, 24 questions, including demographic information, the Likert scale questions, open-ended questions because I wanted to get more into the qualitative, kind of the reasons why either patients were turned away from medical interventions and or surgical interventions, and also how many valve replacements are actually being done. And we had our study approved by the IRB here at NEOMED, and we surveyed cardiothoracic surgeons throughout the United States and a few global communities as well. We recruited them through the Heart Surgery Discussion Forum and the Society of Thoracic Surgeons. We had 220 surgeons voluntarily enroll in the study, with 213 reporting they had surgically treated patients with IV drug use specifically. And these patients did have endocarditis, they had vegetation, most of them needed heart valve transplants. 176 participants fully completed the survey. We did have asked a couple of questions about morality and culture. Some of those surgeons did not want to talk about morality and culture, but for the most part, 176 out of our group did fully complete all questions. And 50% of participants have been practicing surgery for over 20 years. So we've had a variety of different, surgical perspectives, different age groups, different races and ethnicities. And 4.6 participants practice outside of the US. Some of them were trained in the US, but now currently practice outside. So I'm going to give you guys two case studies that I actually put in the survey because I wanted to get their perspectives, the surgeons' perspectives of these cases. These cases are based of two situations I had in a local hospital that I was called for a clinical ethics consult, one of which Melissa basically was denied a heart valve transplant. So Melissa's a 24-year-old female. Okay, so we're not in that 35 to 45 age range, with a 12-day history of fevers, chills, arthralgia, chest pain, shortness of breath. She's acutely toxic on physical exam, rapid respirations, and an echocardiogram. Has a significant mitral vegetation, so the vegetation's pretty high. She does have a history of IV drug use. I will tell you that Melissa had been working with an addiction counselor early on, but when she got to this stage, mental health was not called, addiction services was not called. It became a matter of medical teams communicating with surgical teams, and at no point during her hospital stay, as she's being evaluated, this was addiction counseling, mental health care experts called to the table. So she is admitted and begins a trial of broad spectrum antibiotics. Okay. These antibiotics don't work. So that was the first line of defense, like how do we get through this vegetation? And so I put this case to our cardiothoracic surgeons in our survey and said, okay, what next? What would you do? Is this now a candidate that you would consider, based on just the brief background of this, for a heart valve transplant? Young, female, so forth. The second case is Chuck, 27-year-old male, presented to the ED with a 4-day history of fevers, chills, headache. Further exam reveals cerebral septic emboli with non-hemorrhagic transformation, aphasia, distal limb emboli. He has a history of bioprosthetic mitral valve replacement. Okay, so he has gone through these procedures before. He's gone through the big gun antibiotics. And now he's gone through surgery before. Neurologic consult indicated no obvious contraindications for anticoagulation and surgery. He's continued to use intravenous drugs intermittently. Both of these case studies were reported to be challenging among many of our respondents, but not all. Some of our respondents, like, these are the typical cases we see, but now we're starting to see individuals that are 35, 40, et cetera. At this point, we were starting to get data. We got about 50 respondents early on, and it was pretty positive of these are candidates. We're going to consider them for heart valve transplants. They're young. They have the ability to, possibly succeed from the surgery. However, when we started posing the questions about culture and the morality of IV drug use and mental health support and all those, the surgeons were reporting that this is now getting a little bit more complicated, especially if these two individuals either didn't have a support system or did not have mental health support through the medical and surgical interventions and beyond. Okay. So the other element that we were wanting our surgeons to give us more information about is if they had similar cases and these individuals, as presented, already had a valve replacement. Now, would you just give one? Would you give two? Would you give three? Now, keep in mind for endocarditis and for those who have had successful surgery, 7 years down the road, they're going to need another valve anyway, just by nature of valve replacement. They don't last a lifetime. They are often replaced, 7 to 10 years. And so aside from just the natural progression of having a replaced valve, we were more concerned about would you be willing to replace valves of individuals that had either a previous history of addiction or ongoing struggling with addiction. So 25% of our respondents said, we're only going to do one valve, about a quarter. I will say in Northeast Ohio, when our initial study, before we did the national study, it was about 50%. Two valves, national study, 60%. Three valves or more. And there was a couple of individuals that, hey, I'll do 4 and 5 if they need them. I'm going to support them, but I'm also going to make sure that we also have additional medical and mental health support. And that was about 15%. So the qualitative comments, I'm not going to read through all these, but you guys can kind of get a glimpse of some of their perspectives. I'm looking at number 3 here. If patients continue with IV drug abuse after their initial valve replacement, they're not offered a second operation. 4 operations. This is our 4+ operation, folks. Young, healthy, had kids and a job, good social support. Is difficult to prove recurrent IV drug use. We were noticing more and more individuals that were willing to do 2, 3, or more. They were very much looking at the social dynamics of the situation, support systems, whether somebody had kids or not. That really came into the forefront. The last guy, I have done 4 reoperations on a single patient until we came up with a contract to not operate on recurrent IV drug use of patients. And we're going to talk about the lack of policies and so forth. So the other, and like I mentioned, it was a 25-question survey, mixed methods. We really went into depth. Knowing our initial work was going to point to certain biases and certain perspectives of this patient population. We really wanted to understand the perspectives that may be factors motivating healthcare professionals to not do antibiotics, not do valve replacements, and so forth. So we looked at moral problems, medical problems, social problems, and others. Other tended to be more of the cultural elements. We did have a surgeon that said he refused to do any type of valve replacement on migrant workers or refugees. So just keep that in mind, back of your head. Moral problem, I said 36% of our respondents, 63, that this is a moral problem. It's a medical problem, 66%, and a social problem, 87%. So these are interesting findings. And as an ethicist, this is the type of stuff that I want to even take a deeper dive into and really understand the background, the training, the policies, the procedures, what are the dynamics in the OR, the medical team, and how can mental health not just help our patient populations, but how can mental health and addiction specialists really call attention to the realities of what's going on here, that this is not a moral problem. We looked at the belief about IV drug use and addiction. So being that it was a social problem, so N of 152 from our survey, we wanted to know, well, what exactly do you mean it's a social problem? Is it because of access to drugs and so forth? So we wanted to even take a deeper dive of that. 104 of the 176 cardiothoracic surgeons, so almost 50%, reported that they've performed a maximum of 2 valve replacements, and followed by 44 reporting a maximum of 1 valve replacement, or about 20%, and 26 report a maximum of 3 or more valve replacements. And the impetus for restricting valve replacements was because of the social or moral aspects of IV drug use, not because of the medical. So in looking at those medical factors, we wanted to understand, is this more about the patients that are not able to get the help that they need, that are still combating addiction, that relapse and require a recurrent infective or valve replacement because of their recurrent infective endocarditis. And so in gathering our qualitative information, there were mixed views about surgery and medical therapeutic interventions with all patients with IV drug use that have been active the past 5 years. And there were very few surgeons that would say, I wouldn't try a valve, at least one, but they need to go through antibiotic therapy first and foremost. I'm not going to basically automatically assume that this is going to be a surgical procedure without some type of antibiotic therapy. Surgeons were more inclined to do surgical interventions when there is a history of sobriety or successful completion of an addiction program. Even if there's relapse, the majority of surgeons are like, okay, I can do 2 or 3. I know this person has persevered, they've tried. I'm more likely to give a second or third. They're also more inclined to do surgery when there's no prior history of IV drug use. And so this is where some of the true indications were coming out. And one of the surgeons was like, yeah, if there's no history of IV drug use, I'll do 3, 4, 5, 6, 7, heart valve transplants. The recurrent infective endocarditis folks, more likely to do medical therapy rather than surgery, especially for those that were active to past 5 years, even with some individuals that had periods of sobriety. They're likely to consider surgery when there's successful completion of addiction programs, mixed views about surgery when there's a reoccurrence of the same or new bacteria. There are 2 or 3 surgeons that said we would continue to do heart valve transplants, but if we have difficulty proving whether or not the patient is lying about their addiction use, and it was kind of a bizarre comment, qualitative comment, that it was just the lack of belief and believability of their patients. And if they had a reoccurrence or they had the same bacteria, there wasn't just the assumption that this is the localized area in which this patient is more prone. It was, this patient's lying to me about their continued use of IV drug use. But it's like 2 or 3 individuals had indicated that. If patients had valve replacement unrelated to IV drug use, surgical interventions are more likely to recommend. For the social factors, this was interesting. If a patient has children or consistently employed, nearly 40% support surgical intervention, at least one heart valve. The patient has support system, 55% support surgical intervention. And that support system, it would be a support system that was throughout the entirety of their hospital stay and post hospital stay. Patient's financial status is relatively little influence at all on whether surgery is offered. So 76%, I'm like, it's not about the ability to pay, it's do they have a support system? Over 90% of our respondents are very likely or almost always initiate addiction treatment as part of the plan. And this was promising, that the surgeons had indicated that they would initiate and work with mental health experts. Now, they weren't always available, but the surgeons would say we would try to initiate that. What was interesting, we're doing a second, or actually a third study now with non-surgeons and medical teams that tend to do antibiotic therapy first and foremost. What is interesting is that they're not recommending as much as the surgeons are for addiction support. So I found that to be maybe a really good talking point post this presentation. 75% are very likely or almost always making a contract or a covenant with patients indicating a third valve due to IV drug use will not be offered. And oftentimes it's not instigated by a hospital policy. It's instigated because the surgeon's like, there's more risk with this third valve or fourth valve, scar tissue, you name it, and the fact that the individual has had an ongoing history of IV drug use. With the recurrent infective endocarditis, folks, if patient has children or consistently employed, only 25% support the surgical intervention. The patient has a support system, 40% support that. Patient's financial status is relatively little influence, and 75% are very likely or almost always initiate the addiction treatment as part of the plan. 53% are very likely or almost always making a contract or covenant with patients indicating that third valve. So the motivating factors for treating recurrent IV drug use, this was more promising. 74% of our respondents said they have an ethical duty to treat patients. So at least trying to have at least one heart valve transplant. Availability of hospital resources, 63.7%. And this is what was interesting. When I dug a little bit deeper about what does this mean, it was oftentimes they're struggling with lack of policy and lack of addiction specialists to help support the patient throughout not just the hospital stay, but post-stay. Supportive healthcare team, 58.2%. Those surgeons that said, if the medical team started off with antibiotic therapy, consulted with the surgical team, kept up with that surgical team and a mental health team, an addiction team, they were more supportive of the entire process and likely to have 2 or 3 heart valves. It's the lack of resources, lack of support from other medical teams that was a deterrent. They also thought the patient's right to receive surgical treatment. 53.4% of our responses said that the patient does have a right if they qualify for the surgical treatment. And if there were previous positive outcomes, surgical outcomes, 35% were motivated to treat for recurrent IV drug use patients. And then 19% reported that it was because of the relationship with the patient that was the motivating factor for either multiple valve transplants or making sure that that patient was getting the resources they need. From an ethics standpoint, looking at the principles of beneficence and non-maleficence, what were the main elements that were considered among this population of providers? Well, the clinical presentation of the patient, probability of success of intervention, to eliminate bias. Many of the surgeons reported that these features about risk to benefit analysis was usually their motivating ethical force. The unique health and social needs of this patient population, there was more positive perspectives coming from the cardiothoracic surgeons recognizing that this is a community issue, and as part of the community, they have an ethical duty to these patients. And then a patient's willingness to be treated for addiction. There was a good number of surgeons, particularly the ones that would offer 2 or more heart valve replacements, that they viewed a more justice approach. Rather than a risk benefit analysis, they're focusing on respecting patients' choices, treating patients with dignity, lack of discrimination, anti-bias, and making sure that there's fair and accessible care. And fairness was the pinnacle of their ethical motivating factor, along with providing alternative care when surgery is not possible. So additional addiction treatment, palliative care, in 1 or 2 cases, hospice care came up as, unfortunately. So the outcome of our study, and obviously I'm not presenting everything because we have just a short period of time, but the main takeaways from our study was that guidance is needed, support is needed, a multidisciplinary approach is key. So when our participants were asked whether their institutions have policies or guidelines regarding surgery in patients with recurrent IV drug use, 71% said no, and 6% reported yes. The remaining are like, well, we're not quite sure. We don't think there is. For those who reported yes, 7 individuals indicated their institution has a 1 valve replacement policy for persons with addiction. So the policy itself says they have an addiction, whether it's recurrent or not, they had a previous addiction, too bad, they only get 1 valve. So that was eye-opening. Surgeons are more likely to perform recurrent valve replacement surgeries, giving patients a second chance at life, and would value more concrete guidance in decision-making, so long as the patients are identified on a case-by-case basis. So ultimately, it was more of a positive. I would say 75% of the surgeons we interviewed really wanted to help patients, but they didn't either have the resources, policies, or they were being told otherwise. You can only do 1 heart valve. This is just a snippet. We had extensive, as you can imagine, that many participants, extensive qualitative data, but I just wanted to bring these up. It would be nice not to have to scrap together the moral courage to deny a second valve replacement for IV drug use, and a policy could back you up. So that's 1 perspective. This is a role for an ethics committee to judge appropriate use of resources for cases of refractory IV drug use, which is interesting. Like, we don't want to do it, make the ethics folks do it. Like, thanks, guys. And then guidelines don't apply to heterogeneous and multifactorial condition. Every patient is different. So we have a splattering of different perspectives out there, and the qualitative data, for the most part, supported the quantitative data, but then it was a little bit more eye-opening from the social, ethical perspective of what motivates or what doesn't motivate the providers. So my call to you guys, and I thank this team for inviting me, is to have an integrated addiction care plan. And I know I'm speaking to the choir. I definitely know I'm speaking to the choir, but those behavioral action plans are so critical. Comprehensive clinical care, like bringing these teams together. And I will tell you, in doing clinical ethics in 3 different hospitals for adults and children, this isn't consistent. And we need a coordinated care management team. I'm glad to see Allie on here for Direction Home. It's like, it's not just what goes on in the hospital, it's like what goes on in the home. And do we have the support system? And if somebody doesn't have family, the traditional family member that's at home, how can we look at support systems in a different way? And how can we coordinate a care management team? So, again, I'm speaking to the choir, but this is so critical, and this came out of this study. And the surgeons are asking for this. So it takes a village to help a patient, and I'm looking forward to questions, comments, your perspectives, your experiences. But I wanted to share some interesting results with you from a national study that we conducted. So thank you.